Start.
Yeah. Good evening to all. First of all, a warm welcome for Bayer ISEC meeting. Today we have our speaker, Dr. Cherry ma'am, about educational background has done MBBS at Mamta Medical College, affiliated by NTR University of Health Sciences in 2012. Later, ma'am completed MS Ophthalmology at Osmania Medical College in 2017. Later, FRC in the year 2022. About work experience, ma'am worked as a 2017, later senior resident at Sarojini from July 17 to December 2017. Coming to later, ma'am has completed a fellowship in Veterina at LVPI Vizag in the year Jan 2018 to December 2020. Later, ma'am joined as a consultant Vitio Retina at Shankar Eye Foundation, Vizag from Jan 2021 to March 2022. Currently, ma'am working as a consultant Vitrio Retina and UITs at LV Prasad Eye Hospital from May 2022 to till date. Coming to ma'am academic activities, ma'am attended many meetings and presented many papers in all the meetings. And recently, ma'am presented paper on ARN in HRS meeting held on 17 December 2023. With this, I'm handing over this session to ma'am. Over to you, ma'am.
Thank you, Mr. Anil, for the kind introduction. So, you must all be knowing that Eylea is one of the important anti-VEGF that we use in the recent, in most of the conditions, especially diabetic macular edema. But one of the most important indication for Eylea from my side would be a neovascular AMD. Why is it so? Let us go through some of the slides and we'll understand better. So what is the important burden on the patients? So we'll be treating these patients on and off, and they are on regular follow-ups, especially the neovascular AMD patients. They need multiple injections and they need to come frequently to our clinic. And the first question the patient asks to is how many injections and how many times I need to come to the OPD. This is their main problem rather than taking the injections. So a study was conducted where you can see that the 72% of respondents in that study agreed that the quantity of injections is the largest unmet need, which means patients need a kind of injection where they take one injection and the next follow-up should not be within 1 month, and they need a long gap between two injections. So the main burden on the patient is they need a kind of anti-VEGF which has extended duration of action, by which the treatment burden will be reduced on them. So if you see the variation in VEGF suppression time between patients, it indicates a need for treatment individualization. The mean duration of VEGF suppression by aflibercept is around 71 plus or minus 18 days, which means it is almost more than 2 months, nearing 3 months, which is actually better compared to other anti-VEGF injections, where patients need to take a monthly injection. And patients coming from far, it is difficult for them. Rather than the cost of injection, it is a cost of traveling burden, which is more difficult for patients to come every month. So we need an injection like aflibercept, where at least you can have an extended duration of treatment. So the duration of the suppression varies up to 16 weeks in patients with AMD. Now, what is TND protocol? In aflibercept TND protocol, the treatment is usually initiated 1 injection per month for the 3 loading doses. As you must be knowing, any neovascular AMD patient, either it is aflibercept or any other anti-VEGF, initially 3 loading doses monthly are important, after which it can be extended to 2 months. But may not be true for other anti-VEGF where they need to be continued every month. So the patient usually receives an injection at every visit with no monitoring. That means no need of any OCT in the first 3 months. You can directly go with the 3 monthly injections, after which you can get an OCT done. See if the fluid SRF or subretinal fluid, intraretinal fluid is present or not, depending on which you can either inject the patient and give a duration of 2 months, or observe the patient and call back the patient after 2 months. And you can treat only if the vision deteriorates or the subretinal fluid or intraretinal fluid comes back again. you must understand that this loading dose of very important. You need not do an OCT doses, because if you do an OCT after 1 month and you see that there is no fluid, it doesn't mean that you should not inject. It is always better to treat very extensively at the initial visit and give 3 loading doses. As you can see in this figure, you need to treat their patients until they are stable. After they become stable, you can extend the interval to 2 months and extend every 2 monthly, and only treat if the fluid again recurs, as you can see in the corresponding OCT picture. So this way decrease the interval to previous stable interval. If the fluid comes back, again make it a point to call back the patient every month till the fluid goes away. Again, once the fluid is gone and the CNVM is dry, you can again extend the regimen. So what is the durability of current anti-VEGF? If you compare the ranibizumab TNV, it requires a high treatment burden and it maintains vision gains through year 2. But if you can see the mean number of injections for ranibizumab is comparatively high when you compare with aflibercept. And if you're giving ranibizumab, you cannot give an extended interval and need to be followed monthly. Similarly, in Hawk and Harrier, you can see that only 39 to 45% of the patients were maintained on Q12 dosing with brolucizumab, which is quite less. It is less than 50%. And if you see the mean number of injections over 2 years, in brolucizumab, it is around 10, and aflibercept is almost similar, but the duration, which means from one injection to the other injection, the treatment duration is less in brolucizumab compared to the aflibercept. So, despite the relatively high concentration of brolucizumab, its relatively small molecular weight means that it has a shorter intraocular half-life, and thus it clears very fast. And that's why we cannot have an extended duration, and it's only 39 to 45% could be maintained with such extended duration. The percentage is actually very less. Now come back to one of my patients. As you can see, is a around 60-year-old gentleman who presented with decrease in vision in the right eye. As you can see in the photo, there is a lot of drusenoid deposits along with a fibrovascular PED with SHREM and a large amount of subretinal fluid. While the left eye, you can see there is no CNVM, but you can see the drusenoid deposits which are corresponding on the OCT scan. Now he was diagnosed as type 1 CNVM in the right eye, and left eye only dry AMD, and intravitreal aflibercept injection was injected. Now you can see on subsequent follow-ups, the CNVM scar is relatively big, so you cannot get a complete near normal vision, but he's been given a regular aflibercept injections, initially 3 loading doses, and then extended the regimen every 2 months. And if the fluid comes back, like in April 2024, we gave 2 more injections, and then in June 2024, again 3 more aflibercept injections. So a total of 6 injections were given. In the last follow-up, he was maintaining 21-25 vision in the right eye, and the left eye was 20-20. And this is a final visit. If you compare the first visit with the last visit, that is from March to October, you can see that the subretinal fluid has significantly reduced, but obviously there is some CNVM scar which has come up, but it depends upon at what stage the patient comes to you. If you see in the first visit itself, other than the fibrovascular PED, there is SHREM formation, which means he came relatively at later stage, but still we could maintain his vision, and he's at present 21-25 vision maintained, and he doesn't require much injections, maybe every year 2 to 3 injections. So he came to that level where the number of injections and the treatment burden, number of follow-up visits have relatively come down. So when given at Q8 treatment intervals, when you compare faricimab 6 mg, it may increase the treatment burden compared with aflibercept. You can see that up to 25.8% of patients receiving faricimab could not be extended beyond Q8 at year 2, which means still the number of treatment duration between two injections is still high in faricimab when you compare with aflibercept. Even ALTER study, it was designed to assess the efficacy of two different aflibercept TND regimens in neovascular AMD, where the primary endpoint was week 52 and the end of treatment was around week 96. You can see that the treatment visit according to TND dosing regimen were 2 weeks or no change or minus 2 weeks according to the criteria. And it has also shown that there was an extended treatment interval with aflibercept injection. Now the criteria is you extend that means you call the patient after 2 months with no visits in between. If there is no fluid on OCT, no loss of vision, the visual acuity is maintained, no increase in CRT, and no new hemorrhage. And you maintain that is the fluid is nothing or visual acuity or no increase in CRT of more than 100. But you call back the patient immediately and shorten the duration whenever you see a development of new fluid or there is loss of visual acuity from the previous visit or development of new hemorrhage. So only when you see these signs, you need to call back the patient immediately after 1 month. But other than that, you can extend the duration between 2 follow-up visits. Even the data from protocol pivotal RCTs, they support the efficacy and durability of aflibercept in patients with AMD, where a multi-center randomized phase 4 study in treatment-naive AMD patients were done. And the mean change in BCVA from baseline and injection number at week 96 was seen. You can see that the mean number of injections were around 10, which is relatively good. And the proportion of patients at week 16 at final visit were comparatively high, which means the treatment burden for the patients has come down. So now this is the most important factor of aflibercept, that the duration of burden for the patients to come back to us every monthly it comes down significantly. And the patients are also quite happy, not only with the results, but also that they're happy that they need not come each and every time, because in neovascular AMD, we know that these patients need multiple injections. And coming every month is not so easy only for the injection. And if you see by week 96, around 60% of patients were maintained at Q12 intervals and beyond. And also 96% of the patients were extended up to Q16. And it is a very, very good outcome in patients with AMD with aflibercept. And the visual gains which were achieved were maintained at week 96 only with fewer injections and increased duration of interval between 2 injections. Now, can aflibercept achieve RCT-like outcomes in clinical practice? Let us go through some of the cases. This was a 71-year license, 3 months. If you can see, the best corrected visual acuity in the right eye is 20/20, in the left eye it is around 20/60. On fundus examination, if you can see, right eye shows some kind of drosonal deposits at the macula, but in the left eye, you can see some kind of membrane which is seen, ill-defined membrane at the macula, along with hemorrhages and hard exudates. By this, a diagnosis of right eye AMD, dry AMD, and left eye neovascular AMD was made. You can see the OCT, corresponding OCT. There is a large fibrovascular PED along with subretinal fluid, intraretinal fluid, and also some hemorrhage which was seen clinically. Now for this, 3 aflibercept injection loading doses were given. Then he was maintaining a visual acuity. Now you can see after 3 loading doses, he was stable for 3 months with a visual acuity of 20/30. But again, these patients, once they get good vision, they are just lost to follow. When he came back after 6 months, now he had a loss of vision in the right eye also, which was 20/20. And you can see a membrane has developed in the right eye also. See a large fibrovascular PED which is seen in both the eyes with the intraretinal fluid. Both eyes aflibercept injection was given. And as you can see in the right eye, with just 1 injection, the vision improved to 20/20 and the left eye is 21/25. But as said earlier, even if the vision in the right eye has improved to 20/20, it is always better to give 3 loading doses in these patients because the visual acuity outcomes and the treatment duration between two injections can be significantly reduced if they are treated very aggressively by giving 3 initial loading doses. Now, this was another patient. Now, look at this patient. This patient is a 68-year-old female who came to me in a position where her left eye is already gone with CFCF vision and scarred CNVM. But in the right eye, which is the only seeing eye, she developed an active CNVM, fibrovascular PD is seen, and the visual acuity was around 20/46/9. For her, 3 loading doses of aflibercept were given. After 3 loading doses, though you can see that the subretinal intraretinal fluid is absent, the visual acuity maintained at 20/40, but still, she being dependent on one eye, I initially did a close follow-up every month. She was stable for 3 months, but as you can see, at 3 months, the vision dropped to 2400. And the 4th dose of, you can see a large amount of subretinal fluid. Now, because she was on close follow-up and 4th injection was injected, with just 1 injection, vision improved to 20/50, but I continued giving 5th dose. And after giving multiple injections, in the last follow-up, she's maintaining around 20/20 vision. So this is the importance of treating aggressively with aflibercept with loading doses and having an extended protocol, because they will have a very good outcome. Getting a 20/20 vision in a patient with CNVM is only possible if you treat them aggressively in the initial visit. And advantage of aflibercept is once the 3 loading doses are given and the visual acuity stabilizes, you can have a little extended duration of follow-up with a good safety profile. So the RCT-like outcomes can be achieved in the clinic with aflibercept TND with a predefined exit strategy. You can have a 3 loading doses, and then depending upon how the vision and the OCT features are, you can increase the duration to 2 months to 3 months. So regular 12-weekly control visits allow timely identification of potential recurrence when treatment should be resumed. In another study also, it was shown that up to 67% of patients treated with a rapid extension protocol achieved dosing intervals of 3 months after 2 years, which is very good. Which means if the patient comes after 3 months, it's only 4 visits in a year. In another study also, it was shown that 75% of eyes achieved dosing intervals of 3 months after 3 years. So a real-world results of aflibercept also showed that the treat and extend regimen in neovascular AMD, the vision was maintained and the recurrence were also seen. But even though the patients were called after 3 months with 16 weeks, they all had a very good visual outcome. And the treatment interval was extended to more than 16 weeks in 64.5% of all cases and 78.9% of PCV cases. So it supports the long-term effectiveness and durability of aflibercept with a proactive TNE regimen. So aflibercept has set a high bar for patient outcomes in clinical trials with a proven efficacy in the clinic. Of all the available anti-VEGF agents, aflibercept binds the most diverse range of VEGF receptors, the key drivers of retinal disease. And as supported by so much of data, it has shown to deliver an improved long-term outcomes with the regular treatment. The most important point from this presentation would be that it offers a flexibility to achieve and maintain the visual gains with intervals of Q4 to Q16 while tolerating some residual fluid and reducing the treatment burden. Thank you. I'm happy to take any questions.
Yeah.
Hello?
Ma'am, we will wait, ma'am, another 1-2 minutes. Then we will close.
Yeah. Let's just. I think there are some questions in the chat.
Yes.
Yeah. There was one question for the naive AMD. What would be the treatment
Is
option?
it visible, ma'am?
Yeah. Yeah, as Dr. Sonali, That's a very good question because neovascular AMD is the most common presentation that we see. There are multiple anti-VEGF agents that are available for neovascular AMD, but it is a proven fact that out of all other retinal conditions, Eylea is the one which acts very efficiently in patients with treatment-naive AMD. It also acts in patients with recurrence, but if you are actually looking at a patient who is treatment-naive, aflibercept works very beautifully. So if you give me an option of multiple anti-VEGF, I would go with aflibercept, because if you start with aflibercept at the initial go, where patient is presenting in the early stage and you treat very aggressively, the treatment outcomes are very good. Like you have seen in one of my patients, a third one-eyed patient, she is actually maintaining 20/20 vision with reduced treatment burden, because initially, even with one injection, the subretinal intraretinal fluid was gone, but still I gave 3 loading doses. You have to treat aggressively. After that, you can have an extended regimen, follow up the patient 2 months, 3 months, and then treatment burden also will be reduced and it acts very beautiful. And the second question is by Dr. Kishore. Is loading dose necessary for all patients? From my practice, it is necessary, because when a CNVM develops, what we see clinically is a subretinal intraretinal fluid, but the CNVM still is active. The chances that if you give one injection and the fluid is gone, and then you call back the patient again after 1 month, immediately you'll see that the fluid is back, because the CNVM is still active. So even though the fluid is gone, it is all. I actually don't do OCT only. At the first visit, if I see a patient of neovascular AMD with subretinal intraretinal fluid, at the first visit itself, I explain the patient that you need 3 loading doses, and the next OCT scan and the vision and the next treatment will depend only after the 3 loading doses are done. I repeat the scan only after 3 loading doses, and depending upon how the OCT is, whether there is any fluid, residual fluid is there or not, depending upon that, I will decide on the 4th injection, or I will just extend my visit to 2 more months. But yes, from my experience, I always do loading doses in all cases. And regarding the TNE and PRN regimen, it depends. Treatment extend or PRN, any protocol you follow, but most of the time I follow treat and extend regimen. But it is individual practice. Every ophthalmologist will have a different kind of practice, whether they can follow TNE or PRN.
Ma'am, it looks like I think there is no other questions from audience. So I think it's good to close, ma'am. Once again, ma'am, thank you so much from your end, ma'am, presentation. So peak time, but till you can time to give a good presentation to our audience. Thank you so much again.
Thank you, Anil. Thank you for giving this opportunity. Yeah. Hello? Hello, I can't hear your voice, Anil. Hello?
Ma'am, meanwhile, so that, yeah, ma'am.
Are you saying something? Because I'm not able to hear the voice. Your voice is getting cut.
Hello?
Yeah.
Okay. Thank you so much, ma'am, once again for your presentation. Thank you.
Yeah. Thank you. Thank you. Thank you.